Hello, wonderful people. What's going on? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my Neuroanatomy playlist. In previous videos, we talked about the olfactory nerve or cranial nerve number 1. We also talked about the optic nerve or cranial nerve number 2, as well as the visual pathway and the defects that can happen in the visual pathway and their manifestations. Example, bitemporal hemianopia. Note that the optic nerve is responsible for seeing stuff, vision, which is a sensation. However, today's topic, the oculomotor, is responsible for moving the eyeball. This is a motor nerve. Is it motor somatic or motor autonomic? Both. The somatic motor fibers is gonna help me move the eyeball, let's say up and down. And the parasympathetic motor part in the oculomotor nerve is responsible for two functions. Number 1, to accommodate the lens. What does that mean? To make the lens circular like this. Why make it circular? So that I can reflect the rays of light just like this on my retina. And this is important for near vision, such as reading a book. So the first parasympathetic function is accommodation of the lens. The second parasympathetic function is to constrict the pupil. Why? Because when I'm trying to read a book, light reflects onto the page, and this light is very bright. It will make me unable to see. So I need to constrict the pupil to permit less light in so that I can read the words and the sentences on the page. Click the like button, click the subscribe button, and let's get started. I have a playlist called Anatomy. I have another playlist called Neurology, and a third playlist called Neuroanatomy. Please watch these videos in order for maximum understanding and retention. Olfactory nerve, sensory or motor, sensory. What kind of sensation? Special sensation, and it's afferent because it's sensory. Special, somatic, afferent. How about the optic nerve? Also sensory. Special, somatic, afferent, or special sensory afferent. Remember, here is your brain. You draw the line in the sand passing by the central sulcus. Anything in front, motor. Anything behind, sensory. Of course, there are exceptions, but this is the rule. Because embryologically speaking, this came from the basal plate and this came from the alar plate, and between them there was the sulcus limitans. I can do the same thing for the spinal cord. You draw the line in the sand. That was the previous sulcus limitans. Anything in front, motor. Anything behind, sensory. That's the rule. Of course, there are exceptions. Basal plate, alar plate. Efferent, afferent. Back to the brain. Here is my line in the sand. Anything in front, motor. Anything behind, sensory. Let's say that I want to see the tree. Oh, vision, that's sensory. That's why the primary visual cortex is here. This is also known as the striate cortex. Brodmann area number 17. Thank you so much. This is how I see. This is sensation. But how about moving my eyeball up and down, right and left? Well, for this you need something motor in front of the line, not behind the line. And what's that called? Frontal eye field. Frontal eye field will send impulses to my brainstem, to the oculomotor nerve, trochlear nerve, and abducens nerve, 3, 4, and 6, respectively, to tell my eye to move right and left, up and down. Brain and spinal cord are central nervous system, but the cranial nerves and the spinal nerves are peripheral nervous system. Basically, any nerve in your body is peripheral nervous system, except one nerve only, which is cranial nerve number 2, the optic nerve. It is a nerve, but it's part of the central nervous system, and we have talked about this in detail in my video on the optic nerve. You will find it in this neuroanatomy playlist. What's the structural unit of the nervous system? Neuron. What's the functional unit? The reflex arc. Your eye has many reflex arcs or reflexes, the center of whom is in the midbrain most of the time. Here is a soma, here is an axon. The soma or the cell body is here, the axon fiber is there. A collection of somas in the central nervous system is called a nucleus, but a collection of somas in the peripheral nervous system is a ganglion. Today, you will learn about the nucleus of the oculomotor nerve. You will actually learn about two nuclei for the oculomotor nerve. One is motor somatic, the other is motor autonomic, parasympathetic to be specific. How about a collection of axons in the CNS is known as a tract, such as the optic tract, olfactory tract, etc. And a collection of axons in the peripheral nervous system is a nerve. as in oculomotor nerve. So imagine that this is my brainstem, here is midbrain, and here is pons, and here is medulla. The oculomotor nerve emerges from the midbrain, starting as a soma. A collection of somas in the midbrain is called what? The nucleus of the oculomotor nerve. And then what? Then you go outside and then you become an axon. So we will call you oculomotor nerve. And then part of your fibers will rely on a ganglion known as the ciliary ganglion. Why call it a ganglion? Because this is collection of somas, cell bodies, in the peripheral nervous system, i.e. outside the brain, because I have already left the brain stem. See, medicine makes so much sense once you understand what the French toast you're talking about. Quick embryology review. You remember the trilaminar embryo, 3 layers, endoderm, mesoderm, and ectoderm. Let's focus on the ectoderm. It divides into 2 pieces, the surface ectoderm and the neuroectoderm. The neuroectoderm will give you all of your nervous system. The central nervous system comes from the neural tube, but the peripheral nervous system comes from the neural crest. Can someone tell me, where will the oligodendrocytes come from? Since they myelinate the central nervous system, they will come from the neural tube, just like the central nervous system. How about the Schwann cells? Since they myelinate the peripheral nervous system, they will come from the neural crest, like the rest of the peripheral nervous system. How about all of the ganglia, including ciliary ganglion? Well, a ganglion is a collection of cell bodies in the peripheral nervous system. That's why all ganglia come from neural crest. So ectoderm divides into neuroectoderm and surface ectoderm. Surface ectoderm is for epidermis of your skin, hair, nail, sweat glands, lens of the eye, olfactory epithelium of the nose, and epithelium of the mouth, and the anal cavity. The other type of ectoderm is the neuroectoderm, which divides into neural tube for CNS and neural crest for PNS, and all the ganglia, including ciliary ganglia. Remember, gray matter means what? Unmyelinated fibers. But white matter means what? Myelinated fibers. Myelin enhances the conduction of nerve impulses in the neuron. How about in the brain? Look at the difference. The brain is the opposite of the spinal cord. The gray matter is on the outside rather than the inside. And the white matter is on the inside rather than the outside. Who myelinated the brain and the spinal cord? Oligodendrocytes. But who myelinated the nerves, whether cranial or spinal? Schwann cells. If I told you that a nerve left my brain and went to supply something else, it started in the brain and went outwards. If you go out of the brain, you are a motor nerve, which means efferent. Because it's motor, that's why we call it oculomotor nerve. Is it somatic motor or autonomic motor? The answer is both. It is somatic motor. We call this general efferent or somatic efferent. As for the autonomic part, it is called general visceral, which means autonomic, efferent because it's motor. This originated from the oculomotor nucleus, which is motor, somatic, and this originated from the Edinger-Westphall nucleus. Remember that the Westphall is visceral, meaning autonomic. Remember that cranial nerves 1 and 2 come from the forebrain. 3 and 4 emerge out of the midbrain. 5, 6, 7, and 8 from the pons, 9, 10, 11, 12 from the medulla. Don't forget that cranial nerve 11, the accessory nerve, takes a piece or pieces from the spinal cord. That's why it's sometimes called the spinal accessory nerve. So, forebrain, midbrain, pons, medulla, 2, 2, 4, 4. Forebrain, midbrain, pons, medulla. 2 from the forebrain, 1 and 2. 2 from the midbrain, 3 and 4. 4 from the pons, 4 from the medulla. Today we're talking about the oculomotor nerve, which comes out of the midbrain. If you want to download these colorful notes, go to my website, medicosisperfectionalis.com. I help you understand and pass exams. Remember the 3 primary brain vesicles? We had the forebrain, midbrain, and hindbrain. The forebrain or prosencephalon gave us the telencephalon and the diencephalon. The olfactory nerve is attached to the telencephalon, whereas the optic nerve is attached to the diencephalon. So that's cranial nerve 1 and cranial nerve 2. How about cranial nerve 3 and 4 from the mesencephalon, baby, the midbrain? Most of your eye reflexes have their center in the midbrain. How about the corneal reflex? The center is the midbrain. Light reflex, midbrain. Why is this? Because the midbrain gives you cranial nerve number 3 and 4, oculomotor and trochlear, which are responsible for eye movements. That's why. Nervous system could be somatic or autonomic. The oculomotor has both somatic functions and autonomic function. When it comes to somatic, the oculomotor is somatic motor. And when it comes to autonomic, the oculomotor has parasympathetic motor fibers. GSE. GVE, general somatic efferent and general visceral efferent. The word visceral means autonomic. The word efferent means motor. And the word general means what? Something that is not one of the 5 senses. In neuro, the 5 senses are not 5, they are 4, because the sense of touch is considered general. Autonomic nervous system, we have sympathetic, parasympathetic, and don't forget the enteric nervous system, which we have discussed in detail in my physiology playlist. Do we have any sympathetic fibers emerging out of the brain? No. Do we have parasympathetic fibers coming out of the brain? Yes, indeed. And they are only 4 nerves. Cranial nerve 3, 7, 9, and this is not 1, this is a 10. So oculomotor, facial, glossopharyngeal, and vagus nerves are the only cranial nerves that carry some parasympathetic function. Recall that parasympathetic was rest and digest, whereas the sympathetic was fight-flight. When it comes to sympathetic, it cannot emerge out of the brain because sympathetic is only thoracolumbar. But what if I am sympathetic fiber and I want to reach the eye? Okay, therefore, you have to go out of the highest possible segment. And the highest possible segment is T1 because sympathetic is thoracolumbar. And the highest segment in the thoraco is T1. Okay, so the sympathetic fiber will exit T1. It will enter this ganglion but will not relay in it. It will continue. Same fiber, then the fiber will stop here. The fiber will end and another fiber will start by having a new cell body, soma, in the superior cervical ganglion. What's the definition of a ganglion? It's a collection of somas in the peripheral nervous system, as you see here. And the second neuron will start from here, and this sympathetic neuron will go up, piggybacking on the internal carotid artery and ophthalmic artery to a certain extent, until I reach the target destination, which is the eye. How about the parasympathetic nervous system? I am craniosacral. If I want to reach the head, I am already in the head, because I have my 4 nerves, oculomotor, facial, glossopharyngeal, and vagus. These are cranial nerves that carry parasympathetic autonomic functions. Each one of these lovely nerves has its own ganglion, just like the sympathetic. This sympathetic fiber had the superior cervical ganglion. As for the parasympathetic fibers, the oculomotor has ciliary ganglion. Then the facial nerve has 2 ganglia. One is called pterygopalatine or sphenopalatine. The other is called submandibular ganglion. The submandibular ganglion helps secrete saliva from the submandibular and sublingual salivary glands. As for the pterygopalatine ganglion or sphenopalatine, it helps with lacrimation, i.e. secretion of your precious crocodile tears. Because remember, parasympathetic is what? Secretomotor, not fight-flight. Next, the glossopharyngeal nerve has otic ganglion. Why do you call it otic? Because it's next to otto, your ear. Oh, ototoxicity, otoscope, etc. Yes, indeed, otic because it's in the ear. And that's why the parotid gland is called parotid. Parotid means para-otid, para-otic, parallel to the ear, next to your ear. Who supplies the parotid gland with parasympathetic fibers in order to secrete saliva? That's the glossopharyngeal nerve by relaying into the otic ganglion. Side note, don't forget that the facial nerve pierces the parotid glands, divides into the parotid glands, but does not supply the parotid gland. Who supplies the parotid gland then? Glossopharyngeal. Why should I care that the facial nerve entered the parotid gland? Because during parotid gland surgery, you can injure the facial nerve. Big time. The last cranial autonomic nerve is the vagus nerve. Vagus because it wanders. It is vague. It wanders everywhere in the body. What's the name of the ganglia of the vagus nerve? They are terminal ganglia. What do you mean by terminal? They are on the terminal target organ. Oh, got you. Recall that since the ganglia is very terminal, the preganglionic fiber will be very long, as you see here, but the postganglionic fibers will be short and nice right here. Oh, interesting. So parasympathetic fibers have very long preganglionic fiber, but very short postganglionic fibers. Conversely, as for the sympathetic, the preganglionic is very short, from here to here, and I'm done. And then at this ganglion, I'll start a new neuron, and this will have very long postganglionic fiber. Why does the parasympathetic has long preganglionic and short postganglionic, whereas the sympathetic nervous system has short preganglionic and long postganglionic? Has a very important reason that was discussed in great detail in my autonomic physiology series. You'll find those videos in my physiology playlist. So if I told you that there is a nerve that is postganglionic in the brain and called long ciliary nerve. Oh, the postganglionic is long. Do you think it will carry parasympathetic fibers or sympathetic fibers? Since the postganglionic is long, it's going to be sympathetic. Yes, indeed. The long thoracic nerve has sympathetic functions. What if I told you that there are some nerves in your brain known as short ciliary nerve? Do you think they are sympathetic or parasympathetic? They are parasympathetic because parasympathetic has short postganglionic fibers. Long ciliary nerve, sympathetic. Short ciliary nerves, parasympathetic. Reality is much more complex than this, and we'll talk about this when we talk about the ciliary nerves later. Look at this. Here is the preganglionic fiber, then there is the ganglion, and then postganglionic fiber. The preganglionic fiber is usually myelinated, and myelin appears white. And that's why this ramus is called white ramus, because it's myelinated and preganglionic. After the ganglion, I have unmyelinated fibers. No myelin means I will appear gray. Hence, gray ramus. And that's the story of white rami communicanti and gray rami communicanti. You can say communicanti, plural, or communicans, singular. No one cares. What you need to know is that the white ramus is myelinated and the gray ramus is unmyelinated. White ramus pre, gray ramus post. Look at this, look at this. Here is preganglionic, here is the ganglion, and then postganglionic. Preganglionic fibers are B-type, which are thin and myelinated. That's why they appear white in color. But the postganglionic fibers are C-type nerve, which means thin and unmyelinated. That's why they appear gray. Hey, where is your cell body? Where is your soma? Who's your daddy? My daddy is in the CNS, just like this. Oh, you see this? Oh, lateral horn cell. Oh, it has the soma of this long fiber. And then we end here inside the ganglion. Another fiber will start and take over. Starting by my soma, my cell body as a postganglionic fiber exists in the ganglion. And then what? Then the axon continues on. That's what we mean by saying that the ganglion is a relay station. Relay because a fiber ended and another neuron started. Since we're talking about oculomotor today, the preganglionic fibers will secrete acetylcholine, and the postganglionic will secrete also acetylcholine. But what if we were talking about a sympathetic fiber? Its preganglionic will secrete acetylcholine too, but its postganglionic will secrete norepinephrine, i.e. noradrenaline, not acetylcholine. If you are a fiber that secretes acetylcholine, we will call you cholinergic fiber. But if you are a fiber that secretes norepinephrine or noradrenaline, we will call you adrenergic fiber. Remember my olfactory nerve? We started here between the mucosal cells in the roof of your nose. We had bipolar neurons because they are very important for the sensory system, especially special senses. And then we synapsed onto the mitral cell in the olfactory bulb, followed by olfactory tract onto the telencephalon. Olfactory nerve is sensory. It is special sensory afferent or special somatic afferent. As for cranial nerve 2, which is the optic nerve, we started here at the ganglion cells of the retina. Then we pierced the sclera, acquired a myelin sheath, and got covered by the same meninges that cover the brain and spinal cord. The olfactory nerve is also covered by meninges. And I was pierced by the central retinal artery and the central retinal vein. Don't forget that the central retinal artery is a branch of the ophthalmic artery, and the ophthalmic artery is a branch of the internal carotid artery, which is a branch of the common carotid artery, which is a branch of the, well, it depends. If you are on the right side, it's a branch of the brachiocephalic artery, but on the left side, it's a direct branch from the aortic arch. That's some good anatomy right there. After the optic nerve, we have an optic chiasm, which is an equivalent to the olfactory bulb, but here we do not call it optic bulb, we call it optic chiasm. Olfactory nerve, bulb tract. Similarly, we have optic nerve, chiasm, optic tract. And instead of hitting the telencephalon, we will hit the diencephalon. Diencephalon is anything that has the word thalamus in it. Which part of the diencephalon? Lateral geniculate body, which is part of the diencephalon. As for the oculomotor nerve, forget the telencephalon, forget the diencephalon. I am talking mesencephalon now. The word meso means mid. So we're talking midbrain. Here's the midbrain. On your exam, they love to show you slices and dices of the brain, and all of them look the same. So students have hard time looking at this and determining, is this a midbrain? Is this a pons? Is this a medulla? Or is this even a cerebellum? I have no idea what that is. If it looks like a pair of shorts, it's a midbrain. And this is a medicosis way of thinking. Look at this. Oh, right. Okay. The tip of the short is known as the cross cerebri. The entire leg is the cerebral peduncle. Then we have a dark area here and there. What's that called? It's the black substance, substantia nigra. It secretes dopamine, hence nigrostriatal pathway, which is important for movement functions. What if my substantia nigra is not as dark? What if my substantia nigra is very pale? What does that mean? It means that I lost the dopamine there, such as patients with Parkinson's disease, which is a movement disorder. Everything makes sense once you understand what the French toast you're talking about. Then behind this beautiful cerebral peduncle, not to be confused with the three cerebellar peduncles, we have tegmentum and tectum. Also, students confuse the two. Which is the tegmentum, which is the tectum? The one behind is your rectum. Forgive my language. Rectum, tectum, that's behind. That's the most posterior part. In front of it is the tegmentum. This tegmentum has 4 balls, or 2 pairs of balls. The upper pair is called superior colliculi. A superior colliculus on the right, a superior colliculus on the left. Below them, inferior to them, we have inferior colliculus on the right and inferior colliculus on the left. What's the function of the superior colliculi? Vision. What's the function of the inferior colliculi? Hearing. What's the function of the lateral geniculate body? Vision. How about the medial geniculate body? Hearing. So, the tectum has the 4 balls or colliculi, and the tectum is the most posterior. Then, in front, we have the tegmentum. There is a famous nucleus here and here that's called the red nucleus of the midbrain. At the junction between the tectum and the tegmentum, we have this cerebral aqueduct of Sylvius. The cerebral aqueduct of Sylvius communicates between which ventricle and which ventricle? Please comment below. If I have an area surrounding the aqueduct, what would you call it? Periaqueductal. If it looks gray in color, what do you name it? Periaqueductal gray area or periaqueductal gray. Remember that substantia nigra had dopamine, but the periaqueductal gray has enkephalin for pain. When I have a pair of shorts, how do I make sure that the right side of the shorts and the left side of the pair will remain intact? I will raphe them in the middle, and this is called the raphe nucleus. It's in the middle, but it jumps laterally later. Okay, raphe nucleus. Why should I care? Because it has serotonin. So let's review some neurotransmitters. Substantia nigra has dopamine. Periaqueductal gray has enkephalin. Raphe nucleus has serotonin, also known as 5-hydroxytryptamine. How about the basal nucleus of Maynard, or the nucleus basalis of Maynard? It has acetylcholine. If you destroy it, you get Alzheimer's disease. Dopamine has many functions in your brain. Number 1, movement. Number 2, mood. And number 3, antiprolactin. Enkephalin has an important function in your body, which is anti-pain. Serotonin has many functions in your body, including mood. What's the blood supply of this lovely pair of shorts known as the midbrain? Posterior cerebral artery, superior cerebellar artery, and basilar artery. A very important fact in neuro. If this is a cross-section in your brainstem, I don't care. It could be midbrain, pons, or medulla. No one cares. Here is posterior. Here is anterior. Now what? Remember my line in the sand. You draw the line in the sand, correct? Anything in front, motor. Anything behind, sensory, most of the time. If I am purely motor, i.e. purely somatic motor, I will exit anteriorly and ventrally, close to the midline. But if I'm not purely motor, if I am contaminated with something else, such as visceral or autonomic, or such as branchial, for the branchial arches, or contaminated with any other nonsense. If I am mixed and not purely somatic motor, I will exit, yes, anterior, but look at this, I am more lateral. I am closer to the dorsal than to the ventral. So let's stop and think. How about cranial nerve 3 that moves your eyeball? It only moves, right? So it's purely motor and purely somatic motor, so it tends to be more anterior and medial, just like this. But hey, medicos, the cranial nerve number 3, oculomotor, is not purely somatic efferent. It also has autonomic efferent, which is from the Edinger-Wesphall nucleus. Thank you so much for bringing this up. But guess what? The Edinger-Westphall nucleus will be more lateral to the oculomotor nucleus, which is somatic. So that actually makes sense. How about cranial nerve 4, trochlear, or 6, abducens, or 12, hypoglossal? They are purely motor somatic, which means they are anterior and inwards, more medial. However, look for the trigeminal, the facial, the glossopharyngeal, the vagus, and even the spinal accessory. They are more lateral. The first 4 are more lateral because they are mixed. They are not purely somatic motor. Cranial nerve 11 is more lateral because it's called spinal accessory. It has to borrow from the spinal cord, which takes from the lateral branches. So cranial nerve 3 is motor with a little parasympathetic itch. So it will exit anterior and more medial, as you see. As for the parasympathetic fibers, they will be slightly lateral because they are not as purely somatic as the rest of the oculomotor nerve. And all of these will exist together in one bundle that we call oculomotor nerve. But the word nerve does not mean just one fiber. It means gazillion fibers. The red part comes from the oculomotor nucleus, which has many parts and pieces, and this is responsible for moving the extraocular muscle to move my eyeball. This is general somatic efferent. As for the parasympathetic autonomic function, it comes from the Edinger-Westphall nucleus, which is parasympathetic, general visceral efferent. Remember, Westphall is visceral. Who's gonna move my extraocular muscles? The oculomotor nucleus. Who's going to constrict my pupil and accommodate my lens? Edinger-Westphall nucleus. Next, let's talk about the extraocular muscle. Look at this beautiful picture. Here's your left eye. There is a muscle that can pull it up so that you look upwards, superior rectus. How about look downwards, inferior rectus? How about look medially, medial rectus? How about look laterally, lateral rectus? All of this is easy. So the directions are from the name. Lateral will push me laterally, medial will pull me medially, inferior will pull me inferiorly, and superior rectus will pull me superiorly. Now to the two weirdos, the oblique muscles. We have superior oblique, which comes from above, and inferior oblique, which comes from below. When you see the word oblique, think opposite. Oblique with the O is opposite with the O. The superior oblique will make your eye look downwards, whereas the inferior oblique will make your eye look upwards. Of course, they have more functions than this, but let's keep it simple. We forgot one muscle. It's called the levator palpebrae superioris. I love it. Superioris means upper. Palpebrae is your eyelid. We're referring to the upper eyelid. What should I do to your upper eyelid? Elevated. Levator palpebrae superioris. inside this lovely muscle, there is something called superior tarsus muscle, which is a component of the levator palpebrae superioris muscle. Now let's talk about the nerve supply for each muscle. How about you, superior rectus? I am supplied by the cranial nerve number 3, which is oculomotor. How about you, inferior rectus? Also cranial nerve 3, oculomotor. How about you, medial rectus? Also oculomotor. But the lateral rectus is different. Remember that the lateral rectus makes you look laterally, temporally, away from your nose, i.e. abduction, abduct. And that's why it is supplied by the abducens nerve. Why do you call the abducens nerve abducens? Because it abducts my eye. How about you, inferior oblique? Also oculomotor. How about you, superior oblique? Well, look, I have to pass through the trochlea. And that's why I'm supplied by the trochlear nerve, i.e. cranial nerve 4. So to make it easy on you, all of the extraocular muscles are supplied by the oculomotor with 2 exceptions. SO4. Oh, sulfate? Yeah. Superior oblique is supplied by cranial nerve number 4. The other exception is lateral rectus. Some students use LR6. I hate this mnemonic because SO4 is actually something. It's called sulfate. It reminds you of sulfate, but there is no such thing as LR6. It doesn't exist. So it's difficult to remember. An easier mnemonic is the abduction is by the abducens. Since abducens is number 6, lateral rectus, which abducts, is supplied by number 6. For the super sophisticated, why do I need sympathetic here? Remember that sympathetic is fight-flight, right? Yeah. Which means when I'm running from a tiger, I need to see better. So I better elevate the upper eyelid in order to increase the visual field, so that I can better run from the tiger. All of this was talking about what? The GSE function of the oculomotor nerve, general somatic efferent. But how about the general visceral efferent function of the oculomotor, i.e. the parasympathetic function? It has 2 functions there. Number 1, to constrict the pupil via constrictor pupillae muscle or sphincter pupillae muscle. And the other is to accommodate the lens for near vision by a muscle known as ciliary muscle or ciliaris muscle. Now to my favorite part of the lecture. Please bring pen and paper and let's go to town. And I need you to use 2 different colors. First, let's draw the pair of shorts, which is the famous midbrain. Amazing, just like this. The oculomotor nerve is mostly motor, so it will start here and emerge forwards and closer to the midline. We have an oculomotor nerve on the right and oculomotor nerve on the left. What have I drawn here? Oh, this is the oculomotor nucleus, which is motor and somatic. I also need the Edinger-Westphall nucleus, which is more lateral to it, on this side and that side. Edinger-Westphall nucleus is visceral, i.e. autonomic, specifically parasympathetic. And the parasympathetic fiber will be just like this. Now what? As the oculomotor nerve exits, what's going to happen? We will meet the edge of the tentorium cerebelli. Oh, really? Yeah. And that's why if I have transtentorial herniation, guess which nerve will be destroyed? Oculomotor nerve. Let's continue the journey. The oculomotor nerve continues and it will enter into the cavernous sinus. Which part? The lateral wall of the cavernous sinus. Please take a moment to let me know in the comment section what are the contents of the cavernous sinus. Okay, so my oculomotor nerve consisting of motor somatic and parasympathetic motor fibers is now in the lateral wall of the cavernous sinus. Then what? We will continue on with this lovely oculomotor nerve until we enter something very important known as the superior orbital fissure. Please take a moment to pause the video and let me know in the comments what are the structures that pass through the superior orbital fissure. After this I entered, then what? Then you will pass through something else known as the tendinous ring. Who made the tendinous ring? The extraocular muscles. Then my oculomotor nerve will divide into superior division and inferior division. The superior division will supply the following muscle. Elevate my eyelid. Levator palpebrae superioris. Make me look upwards. Superior rectus. How about the superior tarsus muscle, which is a component of the levator palpebrae superioris? Well, it is sympathetic, right? So some sympathetic fibers might piggyback with this oculomotor nerve to reach the superior tarsus muscle inside the levator palpebrae superioris muscle. And that's it for the superior division of the oculomotor nerve. We supply the levator palpebrae superioris as well as the superior rectus. Sympathetic fibers might piggyback on the oculomotor nerve until it reaches the superior tarsus muscle. That was the superior division of oculomotor. How about the inferior division of oculomotor? It will supply inferior rectus, inferior oblique, and medial rectus. The nerve to inferior oblique will benefit from the parasympathetic fibers, which will go with the nerve to inferior oblique. What is the function of the parasympathetic fibers? Two functions. Number one, accommodate the lens by the ciliary muscle. Number two, constrict my pupil by the constrictor pupillae muscle. And as you might recall, these sympathetic fibers need preganglionic and then a lovely ganglion. Here is my white ramus communicans, and then the ciliary ganglion, then a gray ramus communicans. After the ciliary ganglion, what would you call the postganglionic fibers? Since this is parasympathetic, the preganglionic is very long, the postganglionic is short, therefore short ciliary nerves, which will accompany V1, which is the ophthalmic branch of the trigeminal nerve. But that's a story for another time. Another clinically important point is that the oculomotor nerve is related to the tip of the temporal lobe of the cerebrum. The tip of the temporal lobe is known as the uncus, and that's why in cases of uncal herniation, I can get oculomotor nerve palsy. Let's review. Here is the lovely midbrain, the pair of shorts. In front of the cerebral aqueduct, we have the nuclei of the oculomotor. The main one is the oculomotor nucleus, which is motor somatic, and the Edinger-Wesphall nucleus, which is motor autonomic. Parasympathetic to be specific. Fibers will exit as the oculomotor nerve. Here we are related to the edge of the tentorium cerebelli, and that's why transtentorial herniation will destroy the oculomotor nerve. Also, we are related to the uncus of the temporal lobe. That's why uncal herniation causes oculomotor nerve paralysis. Then the oculomotor nerve fibers enter into the cavernous sinus, lateral wall to be specific. Then we enter to the superior orbital fissure to enter into the orbit. We'll pass through the tendinous rings of the extraocular muscles. Then my oculomotor nerve will divide into superior division and inferior division. The superior division will supply the levator palpebrae superioris, superior rectus, and some sympathetic fibers will piggyback until they reach the superior tarsus or superior tarsal muscle, which is a component of the levator palpebrae superioris. That's for the superior division. Inferior division will supply inferior rectus, inferior oblique, and medial rectus. The nerve to inferior oblique is important because it will carry with it those parasympathetic fibers that started at the Edinger-Westphall nucleus. From the Edinger-Westphall nucleus in my midbrain all the way until the ciliary ganglion, we have preganglionic fibers. Then the ciliary ganglion, followed by postganglionic fibers. Preganglionic is long. Postganglionic parasympathetic is short, hence short ciliary nerves, accompanying the ophthalmic branch of the trigeminal nerve, specifically the nasociliary branch. And we'll talk about this in greater detail when we talk about the trigeminal. Parasympathetic fibers supply the ciliary muscle to accommodate the lens for near vision, and sphincter pupillae muscle to constrict my pupil for near vision. Because remember, reading a book is a parasympathetic function, but running from a tiger and elevating your upper eyelid is a sympathetic function. Where did these sympathetic fibers come from? They were piggybacking on the internal carotid artery, but they originally relayed into the superior cervical ganglion, which is sympathetic, but they originally had their root at T1, first thoracic segment of the spinal cord, because sympathetic is thoracolumbar. Since this is parasympathetic, the preganglionic and the postganglionic fibers will secrete acetylcholine, #cholinergic. If you enjoy my lectures, just remember that I used to hate anatomy in medical school. If you hate anatomy today, you can be better at anatomy than me, I am sure. Just study it diligently every day. Now let's take it to the clinic. Clinically oriented anatomy of the oculomotor nerve. Don't forget to click the like button. We'll talk about cranial nerve 3 palsy, which is oculomotor paralysis. We talk about posterior communicating artery aneurysm. We'll talk about the distribution of fibers inside the oculomotor nerve, and quick review of cavernous sinus thrombosis. How does cranial nerve 3 paralysis or oculomotor palsy look like? Let's imagine that my left eye is healthy and my right eye has oculomotor palsy. What's gonna happen? Remember that the oculomotor used to elevate the upper eyelid. Without it, I get ptosis or droopy eyelids as you see here. Let me make it even more droopy, just like this. Oh, I can't see. All right, then what? Since the oculomotor, may he rest in peace, used to constrict my pupil thanks to the Edinger-Wesphall nucleus, without oculomotor, I get mydriasis or blown pupil. Look at the size of this pupil, normal. Look at the size of this pupil, blown out of proportion, dilated, mydriasis. Since the oculomotor is now toast, guess what? Superior rectus, gone. Inferior rectus, gone. Medial rectus is gone. Inferior oblique is also gone. The only two muscles left are superior oblique, because they are not supplied by the oculomotor, and lateral rectus, because they are supplied by the abducens, not the oculomotor. What does superior oblique do? It will make me look down. Since this is still functioning, I will look downwards. And the lateral rectus is also healthy, so I will abduct, i.e. look laterally. Therefore, in oculomotor paralysis, my eye is looking down and out. So, cranial nerve palsy signs and symptoms. Droopy eyelids, down and out, blown pupils. I'm droopy, I'm down and out, and I am blown out of proportion. What are the three arteries related to the oculomotor nerve? Look, here's the oculomotor nerve emerging from the midbrain and going towards your eye. Okay, here is one on the right and one on the left. And then we need to talk about arteries related to cranial nerve number 3, which is the oculomotor. Did you know that the famous philosopher Immanuel Kant famously said, "The starry heavens above me and the moral law within me fill the mind with ever-increasing wonder and awe, the more often and the more steadily we reflect." Little did you know that the oculomotor nerve is Kantian at heart. Quote, "The posterior cerebral above me and the superior cerebellar beneath me surround my neck with ever-enlarging and ever-increasing aneurysms, the more they swell and hug me." If any of these lovely arteries develop an aneurysm, guess what? They can compress on the oculomotor nerve, causing oculomotor palsy. For example, look at this. This is the posterior communicating artery, or PCOM for short. If I have a right posterior communicating artery aneurysm, it can press on the right oculomotor, causing right oculomotor palsy. So my right eye will have a blown pupil, down and out, and ptosis. Next, let's talk about the distribution of fibers inside the oculomotor nerve. All of this is the oculomotor nerve. On the inside, we have the somatic motor fibers in the middle, in the center. These will supply the extraocular muscle and the levator palpebrae superioris. As for the parasympathetic fibers that came from the Edinger-Westphall nucleus, the parasympathetic is peripheral, not central but peripheral. Amazing. So the somatic motor is in the middle, but the parasympathetic is peripheral. So let's suppose that I develop an aneurysm pressing on the oculomotor nerve from the outside. Which fibers will be destroyed first? The parasympathetic fibers or the somatic motor fibers? Answer, the peripheral ones. The parasympathetic fibers will be destroyed first, which means if I have an aneurysm or uncal herniation or a tumor pressing on me from the outside, guess what? I will lose my pupillary constriction and accommodation before I lose the movement of the extraocular muscle, which means I'll have a dilated pupil before I have paralysis of the extraocular eye movements. But how about trauma? Well, trauma, of course, can destroy the entire nerve by severing it, and this will affect both of them at the same time, both the central and the peripheral fibers. But let's think of diabetes. Oh, diabetes or ischemia in general are disease of vessels. Oh, the vessels that supply the nerve are toast. They have non-enzymatic glycosylation and some gunk, which means the motor can suffer first, which means I get paralysis of the extraocular muscle first. How about cavernous sinus syndrome? It can affect everything here. How about a stroke in the midbrain, which is the origin of the oculomotor nerve? Of course, it can affect the entire oculomotor nerve. Not just that. Remember that the crus cerebri, the tip of the short, has motor functions to the rest of the body. Oh, because they have the corticospinal tract running in them. So midbrain stroke will destroy my oculomotor. It will also give me contralateral hemiplegia. Last, cavernous sinus syndrome. Look at your kind eyes, lovely nose. This is the dangerous triangle of the face. If you punch me in the face in this dangerous triangle, infection can spread deep into the cavernous sinus because the veins that drain this area communicate with the cavernous sinus in my brain. What's going to happen? You will destroy everything that passes through the cavernous sinus, including the oculomotor nerve in the lateral wall of the cavernous sinus. So I get what? Double vision. I can also have intracranial hypertension. I can also ruin other nerves and I will suffer from motor and sensory symptoms. I can also lose the parasympathetic fibers of the oculomotor. How do you diagnose cavernous sinus thrombosis? It's a clinical diagnosis and CT scan will confirm it. The infection is so bad, so forget oral and give me intravenous antibiotics and try to drain this gunk. This is a very ugly disease. So please, don't hang around with useless people. We will elaborate on cavernous sinus syndrome in the next video. Next, let's answer the questions of the previous video on the visual pathway. Remember, here is the eye, retina, optic nerve, optic chiasm, optic tract, lateral geniculate body, then optic radiation onto the primary visual cortex. We have talked about all of these defects and what's going to happen with each one. Today, let me tell you about number 12. Let's suppose that I have an internal carotid artery aneurysm pressing on the lateral aspect of this optic chiasm. The lateral aspect of the optic chiasm contains temporal fibers, which are responsible for the nasal visual field. So I will lose the nasal visual field in this eye, which is the left eye. As for the other eye, it will be completely normal. The questions of last time. This deficit is called what and caused by what? How about this one? Name the deficit and try to localize the neurological defect. What do you call this? Of course, we call it from the perspective of the patient. Okay, what do you see here? I see lower loss, so let's call it lower. Is it everything lost? No, only half is lost, so hemianopia. This is lower altitudinal hemianopia, aka lower altitudinopia. What can cause this? How about damage of both of my cunei or cuneus gyrus in my primary visual cortex on the right and on the left? Remember that the cuneus gyrus is above the calcaline sulcus. If it's above, it will control the lower vision because of the crisscross action. How about this? Name the visual deficit. I'll call this upper altitudinal hemianopia. What can cause it? Lesion to both of my lingual gyri. Remember that the lingual gyrus, which is part of the primary visual cortex, is beneath and below the calcarine sulcus. If it's below, it's going to be responsible for the superior vision, right and left. Quiz time. I have 2 questions for you today. Number 1, please name the muscles that are responsible for pulling my eyeball down and out in cases of oculomotor palsy on the right side. The second question for you is, what is the only cranial nerve that leaves not from the anterior surface, but from the posterior surface of the brainstem? Please let me know your answers in the comments. You'll find the correct answer in the next video where we talk about the trochlear nerve. Do you want to learn about ophthalmological surgery, trauma surgery, orthopedic surgery, pediatric surgery, and much more? Download my surgery high yields course at medicosisperfectionalis.com. It will also teach you about the different types of shock, like cardiogenic shock, hypovolemic shock, septic shock, anaphylactic shock, neurogenic shock, etc. To learn about angina, myocardial infarction, ischemic stroke, hemorrhagic stroke, rupture of the posterior communicating artery aneurysm, which can give me subarachnoid hemorrhage, the worst headache of my life, arrhythmias, ARDS, drowning, toxicology, and much more, download my emergency medicine high yield course at medicosisperfectionalis.com. If you want help with pharmacology, I have the entire pharmacology series on my website, such as my antibiotics course at medicosisperfectionalis.com. There are more than 1,600 free videos on this channel, plus more than 300 premium videos available only to those who click the join button and choose the highest tier. Please subscribe, hit the bell, click the join button, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my premium courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.